Yeah.
Like legit ones that you need.
All right. Before.
So for evening.
Hold on. Give me 1 second so I can write it all down.
Rachel, can you mute, please?
Okie dokie, guys. We're going to go ahead and get started. So we're going to talk about some issues related to nutritional deficiencies. Kelly shared with me a lot of stuff that we're going to go through today. This is not going to be all encompassing, though. So we're going to go through some high points of things, really get you guys thinking a little bit more about what you're going to see actually when it comes to nutritional deficiencies, and not get into the very minutia parts of things like some of the physiology and some of that kind of stuff. So we're going to go through some stuff. As we go, we will play this little game. I'll let you guys know whether you're going to be buzzing in or writing the answers down on your little board and sharing answers. Okay, so those are the two different things you might do. To buzz in and answer a question, or to write something down when everybody gets the opportunity to do it, and then whoever gets it right, each team gets a point. Okay. Okie dokie. So here we go. Maybe. Is there got it? Oh, I gotta find this screen now. Thank you. Got it. Thank you. Thank you, Nisi. All right. All right, so objectives. We're really going to talk about risk factors for nutritional deficiencies, thinking through what patients you guys are going to interact with on a regular basis, whether that's in the clinic, whether that is in the inpatient setting that are potentially at risk for nutritional deficiencies. And really thinking through some of the anatomical sites related to how functionally people become nutritionally deficient, and how that alters their absorption and how it causes malabsorption. Okay, so we'll go through some anatomy too. Hooray, isn't everybody's so excited to think about anatomy. Boo, hiss, that's why we're pediatricians. But the other thing we're going to do is talk a little bit about the diagnostic irregularities that you'll see. So the real clinical presentations of this is what somebody shows up with, this is the nutritional deficiency you need to think about, right? Most common one for that is going to be something like pallor equals iron deficiency, right? That kind of stuff. So that's why I said to Scott, I'm stealing some of your physical exam Friday thunder potentially, not this week, but for the future. So we'll go through some of that stuff too. Okay. All right, so first topic, this is a write down answer. For each one you get correct, we'll give you a point. I want you guys to think about what things set somebody up for risk factors for nutritional deficiency, okay? So it can be diagnoses, it can be things that we do to people. What kind of things set people up for nutritional deficiencies, all right? Let's see, I've got 8 things, but you guys may have more, all right? But we're going to hit on the top 8 that I can think of. Ooh.
I'm splitting.
Yellow team. Oh, yellow team. Yellow team. All right, guys. They're all that good. All that good. Okay. For those of you guys who are going to do some nutritional deficiencies, think about things that are going to impact nutrition. You guys are write stuff down. All right, you know what, the yellow team passed for this one, but let's go ahead and show our answers. So, red team, what do you guys got? Okay, go ahead. Awesome. Awesome, awesome. Okay. Green team, what do you guys got? That's you guys. Sorry, you have a purple board. You have a purple board and a green buzzer. Okay, good job. All right. You're my boy, Blue. Lay it on me. What you got? Awesome. Good job. So you guys hit on a lot of things, right? And a lot of non-medical things. That's the thing we always have to take into consideration. When you're talking to these families, you also have to think about what are the things that are impacting them, the hidden agenda type of stuff that nobody's going to tell me about, right? Nobody wants to tell you, hey, I'm poor and I don't have food, right? That's a thing that is hard to get to, that you have to really try to figure out by looking at their growth charts, by looking at how they're showing up, they're missing appointments, like what else is impacting them, their access to care type of things, barrier to health cares, right? And you hit on a ton of other medical things. So some of the things I came up with when it comes to risk factors for nutritional deficiency, has talked about them. And this is just more broadly speaking, anatomical disorders, surgical conditions, right? You guys talked about those things, short gut syndrome, but also if you have to have a portion of your pancreas resected, that can cause a problem, right? So a lot of different things, a lot of anatomical abnormalities that can do that. Malabsorptive disorders certainly will do that, fat malabsorption. Any pancreatic issues, a lot of the genetic conditions you guys were talking about, metabolic conditions, those things affect how we absorb things and the different factors that play a role in the absorption, in the breakdown of different nutritional elements. You guys talked about other underlying causes, right? Inflammatory bowel disease. Any pro-inflammatory state does what to our gut? Does what? Decrease in absorption, right? It affects the brush border and how well we absorb things, right? So any pro-inflammatory condition is gonna make it harder to absorb different things. Maturity, right? The gut doesn't work as well as it normally does. That's why we have to go slow with these babies, and we can't just give them a Thanksgiving dinner all the time, right? That's why neck is more common with them. Their intestinal villi are structured differently. Eating disorders is another big one. We do it to ourselves, right? The kids do it to themselves. They cause nutritional deficiencies because of the underlying psychiatric illness that they have, right? One of the things I didn't hear you guys say was medications, right? We do it to people. We cause it, right? We can cause them to have a nutritional deficiency. If I'm giving you chemo constantly, you're not going to want to eat, right? We try to impact that by giving them other medications, but there's some specific medications we'll talk about here in just a second that affect different nutrients that we can absorb and how we absorb them, all right? Long-term parenteral nutrition, obviously, is not a good thing when it comes to absorption, a good thing for nutrition. And then bacterial overgrowth, right? We kill off the good bacteria in our gut. We have short gut syndrome. We take out parts of the gut that can help us prevent bacterial overgrowth. And so that causes competing interests, that causes some fermentation, processes that prevent us from absorbing stuff, right? A bunch of different things. Okay, everybody gets 5 points. Y'all gotta be there on time. You want 5 points? You'll catch up. You'll catch up. All right. So talking about medications. So here's a list of a few medications, the 4 medications that can induce some nutritional deficiencies. What I want you guys to do for each one of them, each one you get a product that is affected by a nutritional deficiency that can be affected by it, you get a point. All right. So what does H2 blockers or PPIs, what does that affect when it comes to micronutrients and their absorption, the things that we can actually have a problem processing? Same thing, broad spectrum antibiotics, Lasix and cholestyramine. Okay. All right. Yes. 45 seconds. Go. Twenty seconds left. 20 seconds. Five, 4, 3, 2, 1. And time, she's up. Okay, so what'd you guys come up with? What is affected by H2 blockers or PPIs? Calcium? Protein? This is the biggest one. B12, why? Well, not necessarily because it doesn't bind. Yeah, there you go. The production of an intrinsic factor, right? Increases your absorption of B12. You don't have an intrinsic factor. Shut up, clock, be quiet. Right? So PPIs, H2 blockers can affect our B12 absorption. So if you have somebody who's chronically on that, you need to think about, could they possibly have a B12 deficiency? Right? All right, broad spectrum antibiotics. Biggest one's vitamin K. Okay. Sorry. Who had that? Anything guys? Excellent. Okay. All right, Lasix. Good. Vitamin and vitamin D. Potassium is certainly one we think about electrolytes. So we're thinking kind of more broadly speaking about vitamin deficiencies. Vitamin and vitamin D tend to be the ones. Again, calcium metabolism is affected there, right? When we think about Lasix and the problems with calcium, vitamin D is a big portion of that. All right, and then cholestyramine is folic acid. So your bile acids, right, affect your ADEKs. So that's why that happens, along with folic acid and B12. Okay, anybody get that one? Okay. You guys got one. Red got one. Don't worry, I have to yellow's going to catch up in the I have a feeling. Okay. All right, so other medication you have to think about. Yeah, go ahead.
We're on like Lasix all the time, like parents and stuff like that. Did that for like nutrition? Oh, it's something that's gonna have to be like routine checking, like monthly, to make sure that like the levels stay okay, or just if there's issues that come up, then we start doing.
Good question. So I'm going to repeat it for everybody online here real fast. So Zeal is asking for people that are on chronic medications, for instance, like Lasix, on a scheduled basis, should we be screening them for nutritional deficiencies? That kind of sums up a little bit of what you're saying, right? And checking them monthly or anything like that. No, really what you're going to want to do is use your clinical assault, right? Of, okay, this kid's not gaining weight. Like is that because of a water balance issue? We're not taking enough in? Is that because of other nutritional deficiencies? What's going on with this kid? But if they're otherwise growing and developing well, you don't necessarily need to do that. Now, they're going to have other things that are impacting that, right? Somebody's not just on Lasix for the fun of it. That kid has a chronic medical condition. So you have to take that into account, whether that's because of recurrent heart failure, kidney disorder, like they're going to have poor growth to start with. Your antenna need to be up already for those kids. And it's not necessarily wrong to do, but I wouldn't schedule screening labs for them necessarily unless you see a recurrence of behavior. At that point in time, you say, well, yeah, what's going on with this kid? And most of the time, your subspecialists are probably going to be looking at a lot of that stuff. But that's where making sure they are nutritionally complete is a big part of it, right? So if you know somebody's on Lasix, you want to make sure they're taking things that are high in vitamin D and calcium, right, to prevent some of this kind of stuff. And that's the knowledge you need to be passing on to families, not necessarily thinking about screening them when it comes to the disorder. Make sense? Okay. Other big classification of medications are anti-epileptic drugs. Okay. Do not forget about anti-epileptic drugs, and they're horrible drugs, right? They are just horrible drugs for what they cause to kids and the difficulties they give them. Thank God they help their seizures, right? But they do have a higher incidence for the majority of them of causing electrolyte disorders, of causing other micronutrient disorders, okay? Anybody on an anti-epileptic drug, you have to let that at least run through your brain of, okay, what kind of nutritional deficiency might this kid have? You don't necessarily have to know these specific things, but you do have to think about it related to anti-epileptic drugs, okay? All right, so now for a little bit of anatomy, okay? So what we're gonna do is I'm gonna show you guys a portion of, and this is a buzz in, okay? So we're gonna buzz in here, a portion of the GI tract, and I want you guys to tell me either what is affected and malabsorbed, okay? Or what the difficulty in absorption is if that portion of your GI tract is not functioning or is, let's say, cut out, all right? All right. So everybody buzzers at the ready? Here we go. First one is stomach. Oh, is it not working? Okay, blue. All right, blue team. Okay, so B12 can be affected there. Oh gosh, what am I doing here? I'm gonna get rid of this guy. Okay, B12 can be affected. What else? You gotta give me something else. So affects gastrin production. Good. Hydrolysis and protein degradation, right? That's the other part of it. These give me a hard time today. All right. So yeah, so other things to think about are osmotic loads, right? So it does impact starch breakdown, right? So our starchy stuff does get broken down a little bit in the stomach. So if you don't break that down, just like what we do with anything else, if you give a high osmotic load to your intestines, it's going to bring water in, it's going to cause an osmosis, right? An osmotic diarrhea. So it can then push things through a little bit faster and prevent prevent patients from absorbing things as well as they can. Okay. All right. So you guys, we'll give you a point for that. All right. Here we go. Next up, duodenum. Ooh. Ooh. I heard that one over there. Yellow team. Iron, good. What else? Give me another one. Yeah. Say it out loud. Calcium, good. That's another one. Anybody else got some? We'll let you guys go next. Okay.
Also B12.
Also B12. Okay. Fatty acids. Fatty acids are another big part of the duodenum, okay? So you guys got the two big ones. Iron's the biggest one, right? When we think about iron, especially iron overload, so if somebody takes too much iron, remember the duodenum gets affected by that, right? If they overdose on iron, that's a bad place for things to happen, right? Iron and calcium are the biggest ones. There are some other things. Selenium is another micronutrient that happens in the duodenum. It's specific to the duodenum. Then you have some fatty acids, amino acids. Vitamin A is another one, okay? So resection of that is going to result anemia, osteopenia, and then some decreased fat soluble vitamin absorption. All right. All right. Who can guess what's next? Oh, you're wrong. No. Oh, who was it?
B12.
Okay. B12. Good. Good. Anything else for the ileum? So big thing here in the ileum is, what's up? ADEX, good. Fat, fat soluble vitamins. That's your ileum, okay? So just remember that when it comes to ileum. Also B12, cholesterol, but really zinc, basically anything in the ileum. But the biggest ones are going to be your fat and your B12. Okay? All right. Y'all wanted the jejunum, there he is. All right, Scott was waiting. Okay. Boy, good. What else? Tends to be the bigger part of your starch digestion, okay? Your disaccharides, glucose, galactose, and certainly some things like copper, zinc, those kind of micronutrients, all right? But this tends to be more the starchy area, all right? So ileum tends to be more fatty area, jejunum tends to be more starchy area, okay? All right, a little trickier here. So what can resection of the ileocecal valve? Go ahead, Keith. Yeah. Dumping, good. So it causes dumping. What else does it do, though? Bingo. Tell us why, Ashley. What does it do? Absolutely. So Ashley said bacterial overgrowth for those of you playing online. So that's a big part of it. It creates an actual barrier to prevent retrograde transmission of bacteria up the gut. And we just said, one of the things that happens in the small bowel is a lot of starch digestion. Well, once that stuff happens, you get bacteria that's competing for that, causing fermentation, which can then cause more dumping, like what you said. So it's not just the anatomical part of it, it actually creates fermentation, alcohols, esters, out it comes. Okay? All right, cool. All right, last but not least. Hold on. Anybody want to buzz in? Hey, they buzzed in, red team. What are you going to absorb? What's it calling for? Water. We love water, right? So mostly water, right? That's the biggest thing we're going to need there. So if you lose that, you're going to lose your water absorption. Good job. All right, let's get some points out. One thing. That was so bitter. Oh, come out. All right, guys. All right, so the next page is we're going to talk about macronutrient deficiencies, thinking about how they happen, what happens with them. But the next page is going to have a picture of somebody. The first team to buzz in and name this person gets a point. You gotta wait. All right, here we go. Oh, okay. Twiggy, nice. Nice, Twiggy. Does everybody know who Twiggy is? Does anybody know who Twiggy is? Okay, not everybody knows. All right, so tell us who Twiggy is one more time for everybody. Good. So she was a model during the 60s in England, famous for her thin stature, right? That's how she got the nickname Twiggy. And her eyes, yeah, eyelashes. Okay. All right, point for the green team. All right, now they have the black person. Where's your protein? Welcome back. Got your protein. Okay, so we're going to talk about macronutrients just real quickly, then we'll move forward. Okay. All right, so this is much smaller than I had anticipated. I apologize. But when we think about fats, carbohydrates, and amino acids, those are big macronutrients, right? That we're going to be thinking about. When we talk about fats, just remember, proximal 2/3 of the jejunum is fat where it's absorbed, but it's really affected by the type of lipids you're taking in as well, and other ingested nutrients. So we do a better job than babies do in absorbing fat, right? That's one of them to have a very protein-heavy diet. And really, the number to know when we think about fat malabsorption is 6. 6 grams of fat. So if you do a fecal fat, right? Isn't that so pleasant to do, collect fecal fat? Don't y'all want that job? But when we order a fecal fat analysis, looking for malabsorption of fat, the number is 6. If you remember 6 for most of these things, you're gonna be okay. Because more than 6 grams of fat in a 24-hour collection is abnormal. You are not absorbing your fat like you should. You're dumping it out at that point. Okay, so just remember 6. Causes of fat malabsorption, we talked about small bowel disease, right? So if your duodenum's out there, you're not going to absorb it. And really think about short bowel syndrome. It's called short gut now, short bowel syndrome, less than 100 centimeters, okay? Which doesn't seem like a ton, but 100 centimeters is the number for you guys to remember. Bile acids are clearly a big part of this absorption process. So if you have active liver disease, you're not going to make your bile acids and you're not going to absorb your fat as well. Pancreatic lipase obviously is a big part of that. And then lymphatic. So if you have impaired lymphatic flow, remember our lymph tissue is really fat, really chylous in nature. That's why it's that milky kind of texture to it and then look to it. And so the high fat content there, if we have an impairment in flow or production, you're going to have a problem with absorption. You're going to backflow and your fat's going to get dumped out. Okay. So lymphatics, anything to do with lymphatics is a fat problem, right? You got to make sure they have enough fat, they're absorbing fat. Otherwise, you're going to dump it out. Okay. All right, carbohydrates, starch, sucrose, and lactose. The most abundant ones we have, they're digestible. What's a non-digestible carbohydrate? Cellulose, good. And what else? What's a fake one? Not sucrose. Sucralose. Okay, sucralose, sorbitol, right? Those are big ones. The fake sugars that we make now, that we use now, those don't get absorbed very well, right? That's one of the things we use and kind of dump stuff out. Okay. But typically a problem with the enzymes themselves, more so than anything else, and the breakdown products from that. So single functional elements typically are the problem there. Pancreatic amylase, salivary amylase, not as big of an issue. It's typically more of a pancreatic issue than a salivary issue there. Reduced disaccharide activity obviously causes a problem in breakdown. So we get these complex sugars that we can't break down, our body can't absorb, and out it comes. And then decreased absorptive surfaces. So if you have celiac disease, right, you have blood in your villi, so you can't absorb it. You have decreased amount of gut, that'll cause it as well. And then, like we talked about, some of the unabsorbable carbohydrates. All right, last but not least, amino acid macronutrient problems tends to be more of a problem with proteases in the duodenum, problems in the stomach, right, of breaking down those proteins into amino acids. Excuse me. As well as a co-transport issue of actually getting them into the gut itself, right, into the intestinal lumen themselves. So pancreatic bicarbonate is a problem, protease is a problem, and really need to think about the absorptive surface again. So anytime we don't have enough gut absorptive surface, we're not going to absorb things, shockingly, right? Okay. All right, the ones you want to know about, the things you guys are going to need to go and read a little bit more about are the micronutrients, okay? Don't get into too much minutia here. What you want to know when it comes to micronutrient deficiencies, what's the downstream effect? Right? How is that patient going to present to you? Because there's not going to be any other way that you're going to know they have a micronutrient deficiency other than their clinical presentation. Because if you're not keyed into it to start with, you're never going to check that. Nobody ever thinks check a manganese, right? Nobody ever thinks check a selenium, right? Do a CBC, absolutely. So what's the abnormality that shows up on a CBC with somebody with copper deficiency, with zinc deficiency, right? So what are the secondary effects of those kind of things? All right, and what are the clinical presentations, which is going to be the next thing that we do in a lightning round. Hey! All right, so with the lightning round, what we're going to do is there's going to be a picture that pops up. I want you guys to name the diagnosis, okay? Wait for the diagnosis, and then after we do the diagnosis, we're going to figure out what is one of the micronutrient that is affected. It can be a vitamin, it can be a micronutrient, it can be a macronutrient, all that kind of stuff. Okay, so what's the secondary, what's the actual deficiency that causes the problem, right? But first off, it's going to be diagnosis. Okay, so what's that? You buzzing in, all right? So everybody at the ready. We're going to start with the hair. Okay, a lot of this stuff is very superficial. All right, starting with hair, we're going to start with an easy one. All right, ready? It's like Family Feud. All of a sudden, everybody's hands on the buzzers. Here we go. Top 100 answers are on the board. There we go. All right. We got Mason. No, what's the diagnosis? You lost a point. You didn't pay attention. You just lost a point. No, what's the diagnosis? Second. Okay. Next. Who else? Seborrheic dermatitis. That's the diagnosis. What's the deficiency? Zinc can be one of them. What vitamin? B6. B6. Zinc and B6. Okay. So subderm. Somebody like keep still on. Thank you, Lauren. I appreciate it. We'll give Mason a point. We'll give yellow a point for getting the zinc part of it, and then green gets a point for the subderm. Okay. Green with envy. All right. And this one's a little bit tougher. Here we go. Good. Nope. Nope. So it's not the hair itself that you're looking at here. Not KP. It's along that line. So it's a follicular hyperkeratosis, right? So KP is on that spectrum of disease. So keratosis pilaris is a form of follicular hyperkeratosis. Okay. Give him a point. That's fine. I really don't want to deal with the green team and the whining that's going to come from it. So let that be a lesson. Just complain a lot and you'll get your point. Okay, so what causes follicular hyperkeratosis? What vitamin deficiency? If nobody knows, that's fine. 2 of them. Yeah. What? Nope. A. A is the biggest one. Thanks, Mason. Right on time. Right on time. So A is the biggest one. Vitamin C can cause it. Okay, but vitamin A is the bigger one. Okay, all right. Next on the list, this one, focus on the hairs. Nope. Well, okay, so what's the name of the hair? You're right. Corkscrew hairs, good. And so what's the vitamin deficiency? C, excellent. 2 points, good job. Okay, all right, here we go. Here's the next one. Oops, wrong way. Anybody? No. Okay. What's he got going on his head? If he was a baby. Okay, bleep B team, yeah. Don't you break my buzzer, my $8.99 buzzers from Amazon. All right, there we go. So we said bulging fontanelle, right? What causes that? What vitamin deficiency is associated with that? Buzz in if you know. All right, green. Nope. Vitamin A. Vitamin A. Okay. Vitamin A. All right. Last but not least, there's a bunch of answers of what can cause this. What's going on there? Go ahead. Okay, hair loss. We'll call it hair loss. We'll call it hair loss. Don't you dare tell him I did that. Unless you want somebody else to be running this show, don't you dare do it. Yeah, exactly, right? So what can cause hair loss? What vitamin deficiencies cause hair loss? There's a bunch of them. Okay, A? Who said zinc? Zinc, absolutely zinc. What else? Nope, selenium. Selenium. Yep, selenium. Good. So biotin is the other one. Okay. So biotin. Right. Think about all the hair products. Right. They all got biotin in them. Right. For hair growth. Don't they all? I don't know. No, he doesn't know I put that on there. Yeah. All right. Moving on to the eyes. Okay. All right, here we go. The eyes have it. Oops, it keeps in the wrong way. Okay, a little bit tough. What's the part of his eyes that's affected? I'm assuming it's a he, right? So if this was his mouth, what would you call that? If that was his mouth that was inflamed? So yeah, so you would call it an angular cheilitis, right? But this is an angular palpebritis, okay? So that area is inflamed around his eyes. Nope, not B2. Riboflavin, there you go. Look at Mason. Me too. Okay, all right. Next one. It says it on it. Good. So what is it? Okay, well, anemia is the downstream effect, but he's got, right, so iron deficiency can do that. Which other ones? Does folate, does B12? Yeah, folate, B12 do as well. So don't forget those. Don't anchor on iron being the only reason for conjunctival pallor, all right? You can have B12, you can have folate deficiency causing that as well. All right, next, yeah. Yeah, that's what we said, right? No, I didn't. Yeah, they said B6. Okay. Hook him up with a point, Vanna. Good job. That's right. Okay. I don't expect anybody to know this one. Yeah, look at Sonal. Say it loud. The toe spot. Yep. So BITOT apostrophe S spot. So what causes that? Vitamin A deficiency. We are a pediatric ophthalmologist over here. All right. All right. Last one. What's he doing? What's he got? Night vision, right? So what's he maybe have? Good. So night blindness and vitamin A deficiency. Okay. Yeah, yellow team got night vision. They were on it. Chris was on it. Okay. Okay. All right, moving on to the mouth. All right. What did we just talk about? Cirrhosis, right? Everybody gets a point. Cirrhosis. I'm putting it on her. All right. What causes it though? What can cause it? Okay. Zinc. What's one of the most common nutrition deficiencies you guys see? Iron. Iron. Iron, iron, iron. Right? Angular cheilitis and iron for the mouth. Okay. All right. Next one. What's this kid got? All right. What's that called? Glossitis, right? Inflammation of the tongue, okay. B6, B12, folate, iron, again, iron, severe iron deficiency will give you a glossitis. Yeah, we've lost control at this point in time. Sorry, guys. Lauren is she's doing her damnedest. Yes. All right, we're going to go the other direction. Pale tongue. Iron. B12, folate. So basically anything, if you guys see issues related to the tongue, iron, B12, folate. Keep it simple, okay? Those are the biggest areas you need to think about. And then the secondary effect is going to be, most likely they're going to have some anemia associated with it. Then you're looking at, is it microcytic or is it macrocytic? And that will then help you to decide, do I need to think about iron deficiency? Do I need to think about a B12 or folate deficiency? Okay? So areas of the tongue, really think about your folate B12. Not all of them, but most of them, and iron. Okay? All right, what's that kid got? Aphthous ulcer of stomatitis. Okay, so what kind of things can cause a stomatitis? B6, it's a big one. B12, not as much. Iron. Zinc. Who said zinc? Yeah, zinc. And then who else? What if this was more gingival? Scurvy, yeah, vitamin C and scurvy, okay? Yep. Okay. All right. All right, how about the tongue? Going back to the tongue. Now, not the color of the tongue. What do we have? What are the two things you see? Good. So hypertrophy of the papilla and then atrophy of the papilla, okay? So B12, iron. Those are the two bigger ones when it comes to the papilla. So B12 and iron are the bigger ones when it comes to the actual papilla themselves, okay? All right. So this is, you guys have to buzz in for this one, okay? This has to be a buzz in. I want you to name this character. You gotta buzz in. It's from The Simpsons. If you're not a Simpsons person, I apologize. Not Sal. All right, so he would have vitamin C deficiency. He would have scurvy. No, his name is Bleeding Gums Murphy. Okay, so anyway, all right. All right, all right, let's talk about skin real fast. Okay. It's not acne. What part of the face is really affected there? Good, nasolabial folds, right? So typically we think about sparing of that, but if you have accentuation of a rash there, you're gonna think about two big nutritional deficiencies. Zinc, it's usually zinc, right? It's always say zinc. And B6, okay? Zinc and B6 are nasolabial dermatitis, okay? All right, does anybody know what that is? What? No. Yeah, who said that? With a P. Who said the word with a P? Pellagra. Good. Pellagra. So that's what pellagra. What's that? Niacin deficiency. Okay. All right. What about if you had those two things? Purpura and petechiae. So scurvy can do it. Vitamin C deficiency and vitamin K. There you go. Jessica got in the back. Good. All right. And we already talked about that, right? Does anybody know what movie that's from? Oh, y'all make me feel old. Come on. There's a Disney movie from the 90s. There's a lightning
Powder.
bolt. Yeah, there we go. Who said powder?
It's me, Dr. Carney, here to the rescue from my 30s.
Old man Carew came through for me. I appreciate it. Highly recommend Powder if you've never seen it. Great movie. Okay. All right. Come on, Keith. Do better than that. All right, we're talking about the nails as another point. So what are those? Yeah, besides disgusting. Spoon nail. It's called spoon nail. It's green tea. What is it? Iron. So that's why we got buzzers, y'all. There we go. Iron. Okay. All right. What about that?
Janeway lesions.
Nope. Not splinter hemorrhages. Okay. So she's red. So what causes splinter hemorrhage? Talking about Janeway lesions. What? Nope. C. Vitamin C will cause splinter hemorrhages, right? Okay. All right. So anybody know what that is on the nail bed, right in the middle? It's called Bowes lines. B-E-A-U. Nope. Lauren got it. Zinc. Yeah. Zinc deficiency will cause Bowes lines. All right. All right. What about that? There you go. Who buzzed in? What's that? Okay, iron deficiency, and what are you seeing though? Power of the nail bed, right? Specifically the nail bed. So iron will do that, B12, folate, right? Okay. All right, guys. That's all I got. Okay. So, congratulations to Blue team. Way to go, blue team. You have my utmost respect and adoration. That's what you win. Ha ha ha. I know it's not as much as what you wanted, I'm sure. But honestly, guys, when you think about malnutrition, you think about nutritional deficiencies, have a framework for thinking about, we talk about where's the lesion. What's the thing that's going to prevent you from absorbing it? Right? If you have an absorption process, is it somewhere anatomically? Is it something related to your enzymatic properties? Is it something related to your underlying medical condition? That's the starting point for all of this kind of stuff. And to have your antenna up, because it starts with what your stooling pattern is like, what your growth chart looks like, what your eating pattern looks like, right? If you have somebody who completely avoids gluten because every time I do it, my belly gets hurting, well, guess what? You probably have celiac disease, right? And those are the kind of questions you sometimes have to ask for macronutrient deficiencies. Is tell me what you avoid, not just what you eat. Tell me what you don't eat. Why don't you eat it? And also thinking about special populations, medications, all that kind of stuff plays a role, okay? You're not going to memorize, don't try to memorize all these micronutrients. Like you could sit there and read Nelson's and try to memorize this stuff and you'll completely forget it. It's like developmental milestones, right? You can try to memorize it, but unless you put it into practice in terms of what it clinically looks like, you're probably going to get it confused and forget about it because they start to overlap when it comes to B12 and folate and zinc and selenium and all these different things. Think about the key clinical concepts of what they're going to look like for you. Okay? All right. Thanks, guys.